we actually were reading over histories, okay, from yesterday, and there were a couple where we left off, where we didn't entirely get to finish reading them. I think we had Kaya, and who else didn't get a chance to go yesterday reading the revised history? Will. Okay, so what I'll do, I don't know if you guys are near a microphone, but if you can position your person close to a microphone, we'll have you go ahead and read those off from yesterday.
You're closer, you want to go first?
Okay.
All right, who's gonna go first? Will? Okay.
Hello.
And you're such a gentleman. You gave him a desk. I love it. Such a gentleman. Okay.
Okay, so Bob came to the ATR today describing seething and blistering pain in and around his knee. He said that he landed awkwardly after going for a rebound at a basketball game. He describes his pain as an 11 out of 10 when he's walking. Nobody in his family has had a lower extremity injury before, so he's shocked to hear that he may have a torn ACL. There's currently a backlog on surgeries at the hospital, so he'll have to find short-term solutions to lessen the pain, maybe like painkillers now. And he'll need to mobilize his dominant leg as much as he possibly can.
Okay. Okay. So if I remember correctly, Will, from yesterday, the way that you kind of set yours up was actually more kind of in the setting of maybe an orthopedic follow-up appointment, basically, because he'd already essentially been diagnosed from his athletic trainer, basically his primary care provider, in that sense. So okay, good. I like that. Kaya.
Okay. Okay. Emma is a gymnast with a non-dominant medial knee injury. She has had knee pain in the past. She treated this with physical therapy and rest from practice. Emma's injury occurred last night at practice. She was on the beam and performed a dismount, and as she landed, her left knee gave out and she dropped to the floor. Her pain was immediate and throbbing. She has swelling and redness on the medial side of her knee. Emma's pain is a 5 to 6 out of 10 on the pain scale while resting. Emma tried walking and pain was shooting up her leg with an 8 to 10 on the pain scale. Emma is currently taking Advil and icing to help with the pain.
Okay. Okay, very good. Okay, awesome. That's great. Sorry, guys, my dog is being annoying. I gotta go let him out real quick. I'll be right back. If you guys can do me a favor, so we're gonna actually kind of keep going. So I want you to keep these pieces of paper that you had out yesterday. Now we're gonna continue to expand on our documentation. We're gonna get into the objective. We're gonna get into talk a little bit more about history, but then we're gonna talk about the objective, obviously, portion of the exam as well, and go over the assessment and plan. So you guys gonna kind of go ahead and reposition, get your stuff out, and I'll be right back, and then we'll get rocking.
Is that yours too? Oh, I don't move, bro. I don't get out of bro.
Get out of your collection.
Yep, that one's coming with me.
You guys have that up on the screen?
Yeah.
Yeah.
Dang, I should have came.
Told you, just run over to
My computer literally won't connect to the internet. I don't know what is going on here.
Well, you
See,
might as
the good
well
thing
come
about
over.
being
We're
with
in our
us,
classroom.
you don't need your computer.
Just run over to that. Make the run.
Yeah,
He's
right.
contemplating it.
Next time. In back. So
Yeah, you're close. Yeah, you're close. Make the run.
I can't leave T guard.
It'll be all right.
My biomechanics exam that room.
Yeah, that's PTSD.
All of them.
That was unnecessary.
Yeah, I'm sorry. That was incredibly rude.
We all passed, which is what matters.
We did. Speaking of which.
Does anyone know what P stands for in cell?
Plan?
Yes,
Yes,
good one, Charlie. This is
something like that.
good enough.
You're fine.
This is Charlie's one.
Oh. Only if I can take a nap.
Okay, guys. Back. All right. So you guys have done a great job so far with these histories. I really, really like them. Okay. What we need to do before we jump in to basically the objective assessment and plan portion of our documentation that we're doing right now, let's actually talk a little bit more about how we can continue, because I'm going to tell you guys, the history is the most valuable portion of your exam. So essentially, by the time you're done taking a history with a patient, you should already be able to have a very good idea of what's actually going on with them, okay, from a pathology perspective, just by listening to them talk, okay? So really the kind of the golden rule is that if you listen to the patient for long enough, they'll tell you what's wrong, okay? And so ultimately, if you take a good history and you ask the right questions, you'll figure it out very quickly. Okay, but what I want to do really quickly is I want to share with you guys some other questions that you might ask as a part of a history. And these are actually more focused questions. Okay, and we're going to give examples of these kind of, as we kind of go through. Okay, but what I want to do is I'm going to show you guys, excuse me, give me a second to find it. Go this way. There it is. So this is actually, can you guys see this? I probably need to share it actually. Share.
Yeah. We're good.
You're good? Yeah, we're still good?
Yeah, we're good.
Nope,
Oh, crap.
Nope.
not anymore.
Not anymore. Okay. What about now?
Yeah.
Yep.
Cool. Okay. I'm gonna maximize this though. Oh my gosh. All right. So this is actually the believe it or not, the physical form that I wrote when I was the director of athletic training services at my last school. Okay. And they're still using it, even though I've been gone for like 3 years. But here's the deal. Let's actually scroll down here to the PPE itself. All right. And what we're going to go through here, and so you guys have learned about this already, right? Or you're learning about it in Maggie's class, right? So family history, personal medical history, okay? And how this is really important in essentially taking the history. Now, if you guys remember, what is the one thing that we said, even if you're taking really an orthopedic history, what should you always include in your history? Particularly if you know your patient well.
Problems that don't have to do with the injury they're coming in for, like strokes or concussions or stuff like that.
Absolutely. So basically, we need to include any pertinent general medical problems that they have. Of note, comma, the patient has a history of 3 concussions and asthma. So that that's always something that we need to include, right? Even though you would think it doesn't necessarily apply so much, really important to include that. Okay, so obviously going through different kind of areas, obviously different focused areas here. Obviously cardiovascular, okay, respiratory. Now, what we're doing here, you can see if you look at this form, based on the system that we're asking questions about, we're starting to drill down and ask very specific questions. Okay, so for example, if we look at the cardiovascular history, have you ever been diagnosed with a heart murmur, right? Have you ever been diagnosed with an enlarged heart or had an infection around your heart? Okay, and obviously we use those, obviously, very simple language to get that across to patients. And then if they were to say yes, we would drill deeper by asking them follow-up questions, okay? And so you can see how we're focusing in by asking very specific questions within this area, all right? Okay, respiratory history, right? And then obviously we kind of go through more general medical questions. However, now we get kind of down to very specific kind of questions. Okay, so let's say, for example, Kaya, you had your patient that you were telling us about had a knee injury, correct?
Yeah.
All right, so let's take a look at some focused questions that we could potentially ask in the event that we're dealing with a knee injury, okay? All right, so obviously, you know, part of this comes out in our but things like this, you know, have you ever had an injury to your ACL, PCL, MCL, or LCL, right? If yeah, you know, yes. Okay, for example, have they had, and this is a big one, have they had a previous ACL surgery? If they have, what type of graft was used? Okay, and we'll talk more about that later on in the semester, but it's actually, it can be very important. Okay? Because over time, what we've actually found is that there are certain grafts that were utilized, like cadaver grafts, that may not be as strong as autografts like bone patellar bone and hamstring autografts. So it's really important, particularly if they come in and they say, "Can you look at my knee? My knee feels kind of funny, feels a little bit kind of unstable," and they have a history of an ACL reconstruction, maybe using an allograft. Okay, so that's why we would potentially kind of ask more of that focused question. But do you guys see the point, right? Kind of why we would ask that question, right? So ultimately, if they've had long-standing knee pain, have you ever had anything like a cortisone injection to numb the pain in your knee or anything like that, right? If so, how many of you had, right? Things like that. So does that make sense as to why we would kind of try to drill down and ask those questions? Yeah. Okay. So Kaya, we're going to go back to your case now. Okay. So let's say, how can you take focus? What are a couple of focus questions that you could potentially ask her to get her to supply you with more specific history about the knee? Potentially.
Well, you could ask her if she's had injuries in the past.
Okay. Can you actually come a little bit closer to the microphone, maybe that you guys are using? Sorry, I can hear you, but it's really hard to hear you well.
Yeah, your sound is kind of glitching in and out a little bit too
Is it?
for us. Yeah,
Oh, sorry about that.
it's okay. Okay, what did you want me to ask?
Okay, so you had your patient had a knee injury. Okay, what are some focus history questions that you can ask?
What are some focus questions you can ask?
Oh, okay. Well, I can ask her if she's had any like ACL, PCL, MCL questions in the past,
Yeah.
surgeries.
Yeah. Okay.
If she's had surgeries, the dates of those.
Yeah. Okay. Great. Wonderful. Yes. Okay. Now here's the other thing. Specifically, because she's had what we're assuming to be potentially a ligament injury. She basically, came off of the beam during her and had basically immediate injury, right, in falling. One question that we need to potentially think about asking, and you can write this down if you want, remember it. Does your knee feel wobbly or right? That's a very focused history question. Does the knee feel wobbly?
You
Okay.
said this. Feel wobbly.
Are you by chance covering up your microphone? Like,
You know what?
if you're-
It's entirely possible. I'm like leaning over my computer. Is that better?
yeah, it's just like sometimes when you move, you get quieter and then you get louder. So
What I'm gonna do? Let me actually, I'm gonna put in some headphones and I bet you that'll actually kind of fix this issue. Give me 1 second.
okay.
I started thinking my computer is broken.
Yeah, that's what I thought too.
I don't know what you're saying.
right, is that better at all?
Yeah.
Yeah.
A lot better.
Oh my gosh, yes, that's like, yeah, that's so much better. I can hear you. Oh my God. Yeah, that's better. Okay, cool. All right, so another one to think about, Kaya, is asking the patient, you know, does the knee feel wobbly or unstable, right? We talked about that. You brought in previous surgeries. Okay, very good. One more, okay, one more big one that we should ask. All right, so focus history question for the knee. Okay, are you having any clicking or popping, or is the knee locking or getting stuck? Okay, so clicking, popping, locking, or getting stuck. Okay, what that essentially means is using those words for the patient describes what we call mechanical symptoms. Okay, is the patient having what we call mechanical symptoms of locking, catching, clicking, popping? Okay, does that make sense? Okay, cool, cool. All right, very good. All right, let's actually, so Charlie, you had a really good case as well. And not all of you guys had good cases and good histories, but let's actually move on to a little bit of a lower leg scenario, Charlie. Now, I really like this too, because I think this fits really well with Charlie's sister. So Charlie, if I can have you, first of all, if you can move up a little closer for me, that'd be fantastic. Okay, so Charlie, listening to your case from yesterday, that sounded a lot more like, you know, potentially like a medial tibial stress syndrome situation, like shin splint type situation. Yeah. Okay. All right. Now, here's the deal. With that type of problem, your number one priority, Charlie, is to make sure, you know, is this patient, first and foremost, are they progressing to a stress fracture, right? Or anything like that? You know, is there anything here more serious that could be going on that I need to look out for? All right. So obviously, what's one focus history question that you think that we might be able to ask to kind of enhance your history a little bit?
Like, have they had any previous like ankle injuries or like sore sore shins?
Okay. Yeah, potentially that's a good one. But one thing that we really want to ask them, first and foremost, have you ever had a stress fracture before?
Oh, yeah.
Okay. Have you ever had a stress fracture before? Yes or no? And then they'll answer yes or no. Okay.
Okay.
So, and if they have a previous history of stress fracture, then we're going to need to really pay attention and maybe drill a little bit more deeply on that. Okay. So other potentially serious conditions that we might see in that, in this case, right? Was there any trauma to the area? Did you get hit? Was there an accident? Did you take a blow to the lower leg? Because that might result in something that we call compartment syndrome, which can be limb threatening in certain situations and would have to be essentially addressed with a fasciotomy, right? And so ultimately, was there any trauma to the area? Was there any blunt force trauma, anything like that? Okay. So what we're doing, Charlie, as you can obviously tell, we're asking questions that are going to first and foremost rule out the things that are either going to be emergent, right, or serious, and or the things that are going to potentially require complete cessation of activity and potentially orthopedic referral. Does that make sense? Okay, very good, very good. Yeah, and then your question, obviously, about soreness is also a good one, right? But you see how we set the priorities, right? Ruling out serious or emergent things first with our focus history, and then drilling down to maybe more generalized questions. Is that helpful?
Yeah.
Okay, good. All right. Okay. So Bennett, you had an ankle case, correct?
Correct.
Okay. All right. So this would be a good one. All right. So here's the deal. Kind of, staying with our foot and ankle section here, foot, ankle, lower leg section. what are some focus history questions that you might be able to ask your patient in this case?
You would directly, at least I would directly ask them, have you ever sprained your ankle on this side before? Because I guess once it happens once, it's likely to happen again.
Absolutely. Okay. Yep. What else? Yeah, you're absolutely correct. They've had previous sprains. What else do you want to know?
Is it like, have all of your injuries been in the same specific spot?
Okay.
Like your history?
That could be, I mean, yeah, that definitely could be a question. But the other thing too, if they've had a lot of sprains, I'm sorry. One question that you'll need to ask is, does your ankle feel unstable with daily activities all the time? Like, or have you had just multiple, essentially, have you had multiple sprains, with various levels of activity? Because what that could point to, Bennett, the reason why we asked that question,
Yep.
is do they have chronic ankle instability, right?
Okay.
And the fact, because of the fact that they've had a lot of different sprains, does that potentially point to like a more chronic instability type of issue? Because if it
So
does,
like, how would I say it? Like if they're completely healthy before the injury, did they consider it stable type of thing?
yeah, so for example, like if before the injury, if they've never had a sprain, and have they had problems with recurrent sprains since, right? Or does the ankle feel generally unstable just in everyday life? Are they worried they're going to roll it when they're stepping up on a sidewalk or stepping down? Does that make sense?
Yep.
Okay, cool. All right. Okay. Let's see. So Andrew, what did you have for your case? Remind me, sir.
Mine was a knee injury.
Okay, you had a knee injury. Okay. So we've asked some more focused questions there. Owen, what did you have, bud?
Knee injury as well.
Okay. And then, perfect.
I think you're covering your mic again.
Dang it. What about now?
If you stay back, it works perfectly fine.
I'm just going to stay right here and not move.
Oh, you're fine. When you were where you were before was fine. It's just when you like lean really close. That's when I
Okay.
can't hear you.
Trying to stay extremely still and talk very slow. Okay. So, Izzy, what was your case?
I had the medial ankle injury.
Ooh, this is a good one. This is a super good one. Okay. And as we're going to learn, soon, guys, as we're going to learn, medial ankle injuries present differently and have different consequences than lateral ankle injuries. Okay. And we'll talk more about that. Okay. So, excuse me. So with a medial ankle injury, Izzy, what are some things that you think we may want to ask that maybe more of a focus history for medial ankle injuries, which don't happen very often, but they're debilitating?
Well, I'd ask them first if like they've had any ankle injuries in the past, like just either side.
Okay.
And then maybe if they've had any like previous fractures or something like in the lower leg to
Okay.
prevent,
Yeah.
like to make it less stable.
Yep. Now, here's a really, and this is a key question, Izzy. Okay. I'm trying to stay back and stay very still so everybody can hear me. But remember, right, with medial ankle sprains, the one thing that we often see in combination, simply because of the biomechanics of how those happen, we very often see syndesmotic or high ankle sprains associated with medial ankle sprains as well. So we can have disruption of what's called the syndesmosis. So basically, a way to ask that question, a way to ask a patient that question is, do you have any pain further up in your lower leg too? Right? Does it hurt further up, like between your shin bones? Okay. And if it's confusing now, don't worry, I'll explain it and it'll make sense, particularly when we talk about the ankle later on. Okay. Good. So, but does the concept, guys, of asking focus history questions make sense as to why we would do that? Yeah, it's helpful. Yeah, or I'm sorry, Charlie, sorry about that.
No,
Yeah,
that was a
but-
thumbs up.
That was a thumbs up. Sorry, I couldn't see your hand. That like
Oh,
that.
okay.
Couldn't distinguish the thumb from the fingers. Okay. All right, guys. So let's get into obviously now our observation. We have 20 minutes, which I think will be fine. Okay, friends. All right, here we go. So back to the whiteboard here. There she is. Okay, now we're in the observation section of our note. Okay. So what are some things, obviously, within this section that we're going to be looking for? Who can tell me?
Especially since we're looking at like lower extremity injuries, like how they walked in, or like if they came in using crutches.
Yep. Okay. 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 Okay, good. What else? What's another thing?
Like color of the skin.
Okay.
Like if it's bruised or
Ooh.
red or inflamed.
Okay. So, quiz question. Who remembers the medical term for bruising? What's that called? Who remembers it? I don't know if we covered it in intro or not. I don't remember. Starts with the letter E.
Is it a
Heck,
team? No, never mind.
Sorry, Bennett. I didn't mean to cut you off. Ecchymosis, right? So bruising.
I was not gonna get that.
Okay, ecchymosis.
I was not going to say that. Let's just.
Okay, no problem. Sorry. Oh my goodness. Okay, what else? What's another thing we might see?
Like possible fluid.
Okay, fluid. Okay, so what are some characteristics that would describe the presence of fluid?
Like pus formation or blisters or something like that.
Okay, so okay, Charlie, well, I do like that. That does apply in certain situations. So pus formation, and that's not in a lot of situations we're going to see, but it's definitely relevant in some situations. But what about swelling? Okay, swelling or edema. Okay, all right. Okay, bleeding. Ooh, okay, bleeding. Okay, and honestly, guys, within the kind of the injury kind of cascade and what we see with what happens with someone when they have an initial injury, the first few minutes of that are actually going to be bleeding. When they generally tear a ligament or what have you, they also tear the vascular supply generally that supplies that structure, and so there is at least initial bleeding into the area. That does happen, right? So that's good. Okay, what else? What else can we see? So we talked about fluid. What about position of the injured limb? What about muscle? What kind of things might we be looking for there?
Any deformities or any visible deformities?
Okay, visible deformities. And by the way, guys, this is being recorded, so you can definitely take notes here. But if you need to go back to this and refer, okay, it'll be up on Moodle for you. Okay, what else? So visible deformities. If you remember back, and we see this more in chronic cases or maybe even post-operative situations. What about muscle tone? What types of things might we see?
Deterioration.
One more time.
Deterioration.
Okay, what's that called though?
Atrophy.
Atrophy. Oh, okay, what else? What's another thing? Okay, so what's the opposite of atrophy? If I can talk. I know I'm throwing you guys a bunch of questions, but the opposite of atrophy, okay, would be hypertrophy. Hypertrophy, which means really big and developed, maybe overdeveloped. Okay. I had that problem once when I was in college. I was pretty swole for a while. I had some hypertrophy going on. Then I was hypertrophy, but then I turned 30 and it all just went away. That was a joke. Okay. But also increased tone. I can have hypertonicity. The muscle can look, so if something is hypertonic, it's going to look really well defined. It's almost going to look like it's almost kind of in a constant state of being contracted. That makes sense. Hypertonic muscle. Okay, so things to kind of look out for. You guys are doing great. Okay. What about joint position? What about range of motion? What might that look like?
The joints might seize up, so they can't like fully flex out.
Okay, okay. So limited range of motion. Now, here's the deal, Charlie. You're right about that. We have also, depending on the joint, we need to be able to describe in which direction that motion is limited. Okay, so a patient may have, let's say, for example, the knee. They may have limited knee flexion. Full knee flexion of the knee is about 130 degrees. They may only be able to get to 90, right? 90 degrees of knee flexion. Okay, they may have limited knee extension. Okay, full extension of the knee is 0 degrees. They may lack 10 degrees of extension. So they may be, they might have a 10-degree extensor lag. Does that make sense?
Yeah.
Okay. 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 What else? What's another thing that we might notice with range of motion?
Is there too much range of motion?
Ooh, okay. Hypermobility. Okay, that's another thing. Fantastic. Here's a big one. So you guys, and Andrew already hinted at this a second ago with his answer. He said, taking a look at how they're walking, their ambulation. Are they using crutches when they come to see you, or are they like hopping on one foot because they sprained their ankle and don't want to use crutches? Does that make sense? Here's another thing though. What does their posture look like? If we look at the way they're standing, okay, do they have something like genu recurvatum, like if we're talking about a knee, genu recurvatum, okay, genu valgus or genu varum? We'll talk about that. Don't worry about that. But okay, we're going to look at posture, position of the joints when standing. Okay, cool. And then one last thing, okay, we need to observe, and this really, it applies in this case, but we need to look at their what is called their transfers. Okay, here's what I mean by that. So if you tell them, maybe they come to see you and they're if you go down to the ATR, they're sitting on the couch kind of outside of Troy's office, and a table opens up. You're like, hey, come on over. Observe how they transfer from a seated to a standing position. Can they just pop up with both feet, right? Or do they have to like put their hands down, push themselves up, or are they staying on? Right? So are their transfers, are they independent, meaning they don't need help? Okay, does that make sense? They don't need help from the AT to get up. All right. Now, and do they? And so the other thing is, are they using? Do they use their hands? Okay. If they did, we would say that here, okay, transfers are independent with the use of hands. Does that make sense? Yeah. I know I'm throwing a bunch of stuff out there, guys. but I promise this will all make sense. Okay, and then obviously, let's say that they need help. They can't really get up out of the chair, or they have to really push up with their hands, or, you know, use an assistive device to get up. Okay, in that case, they might have modified dependence with the use of hands. Okay. Okay, does that make sense? Okay, cool stuff. Awesome. Okay, so these are things that we would look at, or that we would have in mind, okay, with observation. Okay, now, what's another thing? What's another thing? So we know what we're looking at. What else goes in this section of our documentation? Who can tell me what other things? So we know what we see. What else are we going to put in here?
Would we put anything that they see?
Okay, who can answer this question? Okay, Charlie's question was, do we put anything that they see in this section? What's the answer to that question?
Is it more subjective? Is that where that belongs?
Okay, so to answer the question, Charlie, that's more subjective. So that would go, that information would go in the subjective section of your note, right? Because that is what the patient is telling you. Does that make sense?
Yeah.
Okay, cool. All right. Okay, what about palpation, guys? Palpation goes in this section, right? So palpation over anatomical structures. All right. So if you are looking at this patient, okay, where do they hurt? So if you touch them, right, where are they tender? Where do they hurt, and what doesn't hurt? Okay, and a little clinical pearl here: always start away from the side of pain. Okay, a little bit of advice there. Always start away from the side of pain and work towards it. Whoops. All right, cool. All right, what's another thing that could go in this section, or that should go in this section? We haven't learned this yet, but I promise you we will. So we have our observation, we have our palpation. What else goes here?
Like how the skin feels, or site of injury kind of feels tangibly.
Can you say that one more time, Will? Sorry, I didn't really hear you that well.
Like sort of like the tangible aspects, like how it feels, or how like the skin feels, or like just how it generally presents when you go about palpating.
Yes, okay, I see what you're saying. So essentially, right, how it feels. So how do we assess that? We assess that by doing special tests. There are special tests that we do go in this section as well, okay, in the objective section, okay? All right, actually, what I'm going to do here, I'm going to put this right up here at the top and just title this, because that would be helpful. Objective section. Okay, so remember, if we have, okay, for a SOAP note, SOAP, right now we're on the letter O. Okay, we covered the letter S on whatever day that was, yesterday. And so today we're on the letter O. So the objective section: observation, palpation, special tests. Okay, Very good. Okay, so let's say that we've done all of this and we're confident that we know what's wrong with this patient. Now, what portion of the documentation are we on? We're about to assign a diagnostic label. We're going to make a clinical diagnosis.
We'd be on the assessment then, wouldn't we?
We're on the assessment. Bingo. Yep. Okay. So let's say, for example, a patient comes in with a knee injury. You know, and we'll go back to using that. And so the patient states that they were dismounting from a beam, felt a pop in the knee, followed by immediate swelling and feelings of instability. Okay. You know, on visual inspection, we notice that there is edema, right? There's a little bit of ecchymosis that is down in the calf and lower leg. This injury happened a couple of days ago, but there's a little bit of bruising present. The patient is not able to obviously ambulate on their own. They have to use crutches, right? And so transfers are obviously modified dependent with the use of an assistive device. So ultimately, we get them over to the table, we do some special tests, they have a positive Lockman's, all right? And so based on this exam, and they have a positive valgus stress test and full extension, based on that exam, we diagnose them with an ACL tear, okay? So we make the diagnosis of an ACL tear, and that goes in my assessment. Does that make sense, guys? Yeah, okay. All right, so it's 12:14, we got 6 minutes. Okay, guys, here is, and I know that we kind of keep beating the dead horse here, but this is, you guys, this is so incredibly foundational, so ridiculously important that you get this early, because it will make everything that you do from this point forward so much easier, and you will learn so much faster if you can do this and do it well, right? So what I want you to do for Monday, right, is just go back to your history, and I want you to now rewrite it, add in, I want you to add in some focus history questions to your history, okay? I want you to also then go back, write me an entire objective section utilizing what's here, all right? And then obviously, you know, give me obviously everything from observation to palpation, and even some special tests that you might use. You can Google them if you want to, you know, before we formally learn these, right? You know, and you guys learn how to do these yourselves. So that's what I want you to do for Monday, okay? And then I want you to give me an assessment. Now, why am I having you do this? Because obviously this is extremely important, so that, you know, you guys can develop, you know, practice with this skill. But the other thing that I'm going to do for you guys is that if you get this done for me, as we kind of complete this initial note, this is going to be the template for literally every SOAP note that you will ever write in your clinical experience. It's also going to be an incredibly useful template for your case study assignments. And the other thing that we'll do is we'll use this, and we'll make this essentially a bonus point opportunity once this is done. So we'll assign a bonus point value to this assignment that we can essentially allocate at the end of the semester, okay? You guys can hear me okay? And are there any questions on any of this?
Oh, we're good.
Okay.
Do you
The other-
want like the observation or objective section written too?
Yes. So
Okay.
subjective, yeah. So that's a good question, Bennett. So history gets rewritten. Does that make sense? With focus questions. Then I want you to also write me the objective section using all these components that we've listed. Okay, things that you're looking for, and they may or may not all be present, but you'll be able to tell, right? And you'll be able to work that out when you're writing this. Okay, give me where they're tender, palpation, give me the special test that you use and the results, right? And then give me your assessment. Okay, so that's what you need to do. So everything from S through A. All right, does that make sense? Subjective, objective, and then it's assessment. Any questions on that? Anything that I need to clarify? Okay, are we good there?
Yeah.
All right. So the other thing, guys, that you'll see, I got I got the calendar all completed for the syllabus. So the syllabus is completely and totally filled in. It's up on Moodle. Peruse that. If you have any questions, let me know. All right. So matter of fact, well, yeah, we have 3 minutes. So we can address questions about that on Monday, but we'll touch on that briefly on Monday, and I'll walk you guys through it. Okay, and we'll go over exam dates, quizzes, all those types of things. All right, and I'll show you all of that. But you guys, I am really, I'm really happy with how quickly you guys are putting things together. You guys are doing a great job. So just a little bit of encouragement for you. You guys are learning an incredibly vital skill right now. Okay, and like I said, if you guys can learn this and learn it well, everything that you do from this point forward will be so much easier because you know how to do this. Okay, so that's why we're focusing on this so heavily right now. All right, anybody need anything? Any questions at all? Okay, if you guys need anything, let me know. Email me, whatever you need. Have a safe weekend, a restful and responsible weekend. Okay, and for those of you that have practice this weekend, maybe scrimmages, good luck with that. And I'll see you guys Monday. If you need anything, let me know. Okay.
Thank you, Wade.
Thanks,
Yeah.
Wade.
Bye, guys.
Thanks, Wade.
See ya.